Okay, so today we're going to go through writing a protocol. And the protocol is probably one of the most crucial steps in your project, because it sets everything everything you do afterwards. And a lot of people see writing the protocol as a pain, something you have to do for the ethics, and don't spend a lot of time on it. Do it as quickly as possible. But actually, if you do it well, and if you spend the right amount of time, it will hugely improve the quality of your project. It will guide you into what you need to do. It will force you to be focused. And also, you will write things in your protocol that you can almost copy and paste and put it in your paper afterwards. So the background and the methods and actually the structure of the results, you should already think about at that stage, and it will save you a lot of time later. Okay, so in the next, I guess, 45 minutes, hour or so, let's go through what information needs to be in a protocol and how it needs to be structured. This is as much to satisfy the regulation and the needs of the committees that will look at your work for ethics, for funding, or whatever. And it's as much use to them as it is to you. And actually, it's more for yourself. Like, and when you write it, don't think about it as a hurdle that you have to go through, but as something that is that helps you build your own research project. Okay. So this is one template, and I got this template about 10 years ago when I was doing my my fellowship in epidemiology. It's highly relevant and it's very comprehensive, maybe a little bit too comprehensive in some parts, but it's a good way to learn. It may be that depending on the type of research you're doing, whether it's an intervention trial, an observational trial, there are slightly different requirements, but overall, this covers it all. Okay, so the first section that that you will fill in a protocol is the background. And the purpose of the background is really to explain to a committee that will approve or not approve your study, and to people who are reading your work, and to yourself as well, why your research project is important. Where does it sit within the global body of evidence? What gap does it fill, right? This is the purpose of an introduction in a paper. You explain the work that you do. You explain why the work that you want to do is important and how it will help. And there's a structure to a background that we went through in previous lectures. And think about it as a inverted pyramid. Yeah, you start very global, and you narrow it down. So, for example, if you want to do a study on improving diabetes care in northern Israel, you will start talking about diabetes in very generic terms, explaining why globally it's a problem, and reviewing a little bit the evidence, what proportion of the population is diabetic, who it affects, what are the problems with diabetes, and then you narrow it down. Then you might come to Israel and talk about diabetes in Israel. Does Israel have a higher, lower burden of diabetes compared with the global average, and why? And then you might go into the north compared with the rest of the country. There's a higher burden of diabetes in the periphery, in the north of Israel, compared with the center, and then you can talk a little bit about why that might be, and access to healthcare, etc., etc. And then you might, if you're doing a project here at Ziv, then you might talk about Ziv and give a couple of sentences on, what is Ziv Medical Centre. It's a hospital in the north of Israel that has 300 beds and covers this area. And then talk about diabetes services here and how they're. So you see, you're getting smaller and smaller and smaller, and then you state your problem. You say, what we're seeing here. We're seeing that, I don't know, the proportion of diabetic patients who struggle to have good glucose monitoring is higher than, and we don't really know why, so we want to do a review of, compare our patients with other patients. I'm just taking an example, but you can see how you narrow it down. And I think following the structure is really good. The background is not a review of all the literature on diabetes, right? As a rule of thumb, the background shouldn't be more than 20% of the length of your entire protocol. It's not you're not writing a book on diabetes. You don't need to find every article that was ever written. You need to think about it as a story that you're building, right? You need to convince the reader that what you're doing is really important, and it will fill a gap in knowledge that will improve the health of your patients or your population. It's a story, right? Think about it as an argument. You're trying to convince the person that what you're doing is important, because this is exactly what happens. When you review, if you're a reviewer for an article, you start and you think, oh yeah, this is actually something that needs to be addressed, or not. And most reviewers, most editors in journals will not go past that. If they're not convinced that it's an important issue, they will not even bother reading your methods and your results.
Or that they think there's enough evidence on the subject and there's nothing new.
Yeah, exactly. So you need to show that there is something new, but you need to build it gradually. That is the purpose of the. And if you do it here, then, because it's also an ethics issue, it's not ethical to do research if you already know the answer, or if your answer doesn't actually help in any way. So it's not just for the journals; it's also for the ethics committee, and for yourself. To be sure that you're not wasting time and resources on something that is actually not useful and not important, and is not going to either change care or improve health. So the length, it needs to be brief, it needs to be straight to the point, and generally at the end of the background you can explain the aim of the study. It may be in the background, it may be in a separate section depending on the form, but you need to be very clear to say, we aim to do this, this, and that. And I really like in order to, why are you doing it? So you not just say what you're doing, but you're justifying why you're doing it. And it comes in a later section. But this is the beginning, and it's a really crucial section. The mistake that people generally make is it's way too long. And generally, when I review protocols, I will delete two-thirds of the protocol. Like a very common thing that people do, say for example, this diabetes project, they will start going into a textbook explanation of what diabetes is, and pancreatic function, like kind of physiology, and which is, if you really want to learn about it, you can go and see a textbook, but no one has the time to read 10 pages on the pathophysiology of diabetes or anything else for that matter. So think about that, and always think about who is your audience, and you have to reach the right balance between making a compelling story but keeping it short and brief and to the point. So the next thing that you will include in your protocol is the methods. You've explained why what you're going to do is important. Now you're going to explain how you're going to do it. So here the objective in this template is in the methods. It could also be in the background. It doesn't really matter where it is, but it needs to be there. And we talked about, in the first lecture, we talked about the number of objectives. It should be very limited. You should have a clear primary objective. You can have secondary objectives, but you should have a clear primary one. And it's important because generally the sample size calculation is based on that primary objective, and because your main message is going to be answering the question that you put there. One of the things that people commonly do when they start embarking on research is, as they gather information, start thinking, oh, this would be very interesting as well. And this would be very interesting as well. And what about this? And then you lose the focus, and you waste a lot of time, and then the analysis and the paper becomes very messy, and it's not a positive thing. You want to be very clear about what you're focusing on, and generally it's good in the objective when you write it to have a single verb. If you have "and" in your objective, I'm doing this and this and this and this, that is not one objective, that's 4 objectives, right? So an objective should really be a single sentence with a single verb. It can be to estimating, if you're counting something, you're estimating the prevalence or the incidence of a particular problem. Majd, you're estimating the proportion of PET CTs which have incidental finding in the head and neck, for example. That's a quantitative thing. That's if you're looking at a single group. If you're testing a hypothesis, that surgical approach A is better than the surgical approach B, then you are determining something. You're determining whether approach A is superior to approach B. You're determining whether this exposure is associated with that outcome. But it should be a very simple sentence with a single verb. Yes.
לאובייקטיב, אני מדבר בהתחיל. לאובייקטיב, אפשר להגיד שהפוקוס הוא על שאלה אחת.
נכון.
במידה ואני אקבל תוצאות, אז הצעד הבא הוא 1, 2, 3.
Yes, you can, yeah. So
אני אתמקד, והפוקוס הוא יהיה על שאלה אחת.
Yes.
ובמידה ויש משהו חיובי, אז הצעד הבא להגיע לתוצאות אחרות. אפשר לעשות דבר כזה, כן?
You can, and that's why you have secondary objectives, and you can explain. Just because you have a primary objective doesn't mean that you have a single result. It could mean that, for example, for example, you want to know if I don't know, a particular, there's difference in outcomes according to where people live. So your objective may be, to determine whether place of residence is associated with diabetic control. Okay, so that is your objective. But when you actually present your results, you will have a table with many different, you'll have different strata. You will have the different age groups. You can adjust, and then you can have secondary objectives if you want to. The main difference between the primary and the secondary objectives is that generally the way you design your study, the way you decide how many people you need, it has to be based on one objective, and that's it. That is your primary objective. The other ones you can look at, but you may not have the power to answer it at the same level. What you shouldn't do is go completely outside of your objectives, because suddenly in the middle of your study you decide that something else is interesting. You notice something. You shouldn't lose that idea, but that is going to be your next project, right? It's not, and you cannot do everything in one project. And this is another thing that a mistake that people commonly do. They try to answer every question. They have a great data set, they collected great data, and they think, I can answer that question and that question. Well, that's great. And it's, if you notice if you notice issues that need to be answered, make a note of it, but don't try and answer everything you can in a single paper or in a single project, because you don't have the space in a single paper. You're probably not going to have the time, and you're probably not going to have the resources, and you need to apply the same process through each of these ideas. And it's a great way, generally one question, and answering one question generates another question, and that's going to be your next project. Yeah.
Should the first question be the most important objective? Like in my study, for example, I need to calculate the prevalence of incidental finding in the neck.
Yes.
But actually, it's not the first objective. Like the most important objective is to try to know, based on the SUV, as we see in PET-CT, the risk of malignancy in the future. So maybe first I need to do the prevalence, however. And the second issue is to try to find if there is correlation between SUV or SUV characteristics and the risk of malignancy.
So your primary objective, your primary objective should be the objective. Well, let me rephrase this. Your final result should answer your primary objective. So for you, the prevalence is a step to get to that objective, right?
Exactly.
So when you describe the methods, you will describe that. It's a kind of intermediate step. But if it depends if it's part of the same study or not. If you're doing a study just for prevalence, then what you will do in your background is to say, I am, it will be set up differently. It will say, we don't really know the prevalence of this particular problem, and we need to know this in order to then in future study determine whether incidental findings lead to malignancy. So if you want to focus just on the prevalence, that's what you write. If in this particular study you're already going to look at the outcome, whether or not particular incidental findings led to malignancies, then the prevalence is an intermediate step that you describe, but it's not your primary objective.
Okay, so I should put it like a second objective, not the first. Like the first one should.
I'm not even
Unless
sure.
it's something that you're not doing in this specific study. I'm not sure that I follow, but
I do both. I do, however.
This is in the same study. The same
Yeah,
project.
because I need. However, I do the prevalence, so
So it could be a secondary objective, or it could just be part of the process to get you. So you could say, in order to estimate, in order to determine whether these incidental findings end up being malignant tumors, the first step is to quantify how many incidental findings there are, and then you describe the process. So it's a result in itself, but it's not necessarily your main objective. Like for example, if you're doing a randomized controlled trial, your first table is going to be the description of your population. Now, the objective of your study is not to describe the population, but it's something that you need to do as part of the process. And you explain that in the methods.
This is interesting what you say, because for us, or for me, it was always like the general objective, which encompassed all the specific objectives. And this is different than what I know from my past.
So there's different ways to do it. Sometimes some protocols and some journals will ask you to distinguish between aims and objectives. So and aims tend to be more general, and objectives tend to be more specific. That's another way to think about it. In a way, it doesn't, what is important is that the structure remains the same, that there is an overall objective, and then what you describe is not secondary objective, it's just the way to get to your aim. So you could either say, this is my objective and this is how I achieve it, or this is my aim, and in order to achieve this aim, I will fulfill these objectives, which are basically steps on the way to get there.
Because sometimes, when I written protocols, sometimes I use like a fuzzy verb, like להעריך את הקשר.
Yeah.
estimate.
You estimate the correlation between stuff, and then you don't specify certain parameters, so you're not really very specific on that.
Yeah,
Have to be very specific.
it should be quite specific. The verb is really important, and it should be clear. There's some verbs that personally I really don't like explore. You're not in the jungle. You're not exploring anything. Okay, you counting something, you quantifying, you estimating, you determine. You don't explore. You don't. There's a few verbs like this.
Assess, determine, estimate.
Exactly. It needs to be clear to the reader what you're actually doing.
If you do qualitative studies, you have to explore. Sometimes.
Yes, but even if you're doing qualitative, so you could say evaluate or again determine through a quantitative methodology. But so vagueness is like the objective should be generic, but it still needs to be clear what you're doing. From the verb you use, it should be clear whether you're using a quantitative approach, a qualitative approach, whether you have two groups, whether you're comparing, whether you're just counting. And then, so that's kind of the part of the objective. So you could choose to do aims and objectives, or objective and steps, which is kind of the same thing. The other thing is then to talk about the population. What is your population? And we talked about time, place, and person, and this is a good place to use this this approach. You want to, who are you looking at in terms of where they live, who they are, what time period you're looking at, who is included, what are your inclusion criteria, what are your exclusion criteria. One thing that is really key here is that your inclusion and your exclusion criteria are mutually exclusive. This is a mistake that people often do. They say, well, we have 3 categories, and category A and B are in, and category C are out. So you need to make sure that no one can be in 2 categories. This is a common issue, and also that no one is in neither category. So when you do inclusion and exclusion criteria, this is something that reviewers often look at. A common mistake, this is more of a kind of mathematical thing, but age groups that overlap. So you say, well, my first group is 3 to 15, and my second group is 15 to 25. No, it should be 3 to 14 and 15 to 24, or 3 to 15 and 16. So be careful with these things, where people live, the age groups, and be careful that it's easy to categorize. It should follow a category that is going to be easy, and that you have data to be able to do that. A common thing, for example, is ethnicity is a complicated one, because you don't necessarily have, like you'll say, okay, well, in Israel you will do I don't know, Haredim and secular Jews and Muslims and Christian Arabs, okay? But what if, like, how do you decide? You need to use categories you need to use criteria for inclusion and exclusion that either you have data for, or that people will tell you what category they belong to. If you can't use categories that are fuzzy. Sometimes with ethnicity, it's a challenge, because who decides who is Haredi and who is not Haredi? Or what if you have yeah, well, exactly. Or what if, like, one of your parents is this and one of your parents is that? So you need to think about these things, because then it becomes complicated. And what you don't want is, when you have your patients or when you have your data, deciding at that point which category I put them in. And people don't always fit in boxes. You have to make generalizations. That's okay. And you need to explain that in your limitations. And you should actually have a limitation section in your protocol. So all these things are important. The next thing in the methods is the design of your study. This is quite extensive. Here it's a short thing, but you really need to explain that well. The first thing is the type of study. So we talked a lot about that, the study design. What is the design? Are you doing a survey? Are you doing a case control study? Are you doing a cohort study? Are you doing a cross-sectional study? Are you doing a randomized controlled trial? You need to think conceptually what category my study fits in. And sometimes, like we talked about, like Hannah, your study, for example, it doesn't fit neatly into one of these categories. If it's you're doing a screening tool, for example, well, then you can just say that, or you need to think which of the categories that we described the study fits in. If you're not sure, it sounds, when we do the lectures, it sounds very clear. Sometimes it's not that clear. And that's okay. And then if you're not sure, you discuss it with someone. That's why you have mentors. That's why you have colleagues. And then it's important to describe and mention if you're recruiting prospectively or retrospectively, the the timing is important. Like you really want to describe the design as clearly as possible. And I would refer you for this section to the previous lectures about the study design. So for example, if you're doing a case control, you want to describe how you know, who are the cases, who are the controls, how is the exposure measured, how is the outcome measured, and we'll go through these sections further down, but you really want every single element. If you're doing a randomized control trial, you want to describe how you're randomizing the patient, what is the blinding procedure, all the things that are important in the design. If you're doing a cohort study, you want to describe how you're following patients. Are you doing questionnaires? Are you doing phone calls? Are you going to, you know, if someone doesn't answer, are you going to do a reminder? How many reminders? Literally every single detail. What you know, the ideal thing, the way to think about a good protocol is you should be able to give it to someone else and they should be able to do your study for you. There's enough detail there for them to know exactly what to do. It's like a cooking recipe. Yeah?
This is good.
It's more complicated.
I did something, you
Depends,
know,
yeah.
try to do a Parmesan souffle and then we'll see. No, but yeah, of course. So, and here there are subsections about the study design. You want to talk about the definitions. So this is who is a case, who is a control, who is exposed, who is not exposed. You know, it needs to be laid out. These are not things that you want to think about when you're doing your study. You know, we talked, for example, in the bias lecture about smoking, and you know, oh, if someone smokes like 3 cigarettes a day, is he a smoker, or should I put him in a non-smoker? This is where you describe this, and it's not about right or wrong answers. It's about making decisions. I'm saying, you know, anyone who smokes, or you could have several categories, and you could say I have light smokers, anyone who smokes less than 5 cigarettes a day, anyone who smokes between 5 and a packet is intermediate, and anyone. It doesn't matter how you do it, but you need to spell it out, and you need to stick to it afterwards.
And it can also be like a certain score in a questionnaire tool would be depressed or not depressed.
Yeah, exactly. So, you know, depending on what tool you use for data collection. Yeah, absolutely. You should try and use, by and large, you should try and use tools that already exist if you can. So, for example, you know, if you're going to do a study on depression, there are standardized scales to decide who is depressed and who is not depressed. If you're doing a work on heart failure, there's a classification by severity. So don't try and reinvent these things.
Validated by your language.
You should, yes. So you should try and use tools that are validated. We'll come to designing the tools, which is quality assurance. It's a different thing. And yeah, so standardized definitions, you know, either national, global. So, you know, for example, I don't know, post-op mortality, how far in the, you know, do you look 10 days, 20 days, 30 days? Generally, there are, within the field, there are accepted standards, and you should use those. You only divert from that if you're looking at something so novel that there are no standards, or if there's a very, very good reason for you to divert from accepted standards. And if that's the case, you need to justify why you're not using accepted standards in this part. Yeah. So this is your definitions. Generally, again, if you go back to exposure and outcome, you need to define who is exposed, who is not exposed, and who has the outcome of interest, who doesn't have the outcome of interest. Okay. You need to describe your sampling procedure. We talked about sampling and sample size. Sample sizes, we'll come to it, but here it's about how you actually recruit people. And this is important because this is where you're going to ensure yourself, convince yourself and convince others that your sample is representative of the group that you're interested in, that you're not introducing bias in your study, and that you're using an approach that is valid. Okay, so if you're doing random sampling, you need to explain that. If you're doing systematic sampling, you need to explain that, and you need to not just say it, but actually explain. Like if you're doing a random sample, you need to explain what is the randomization process, what approach are you taking? Because if you say, oh, I'm taking every other patient, well, that's not randomization. You need to say, you know, it's true randomization. I've used a random number generator to choose which people are going to be in my sample, and you need to justify why this sampling method is appropriate for your study.
So this is sampling, not randomization. This is just the sampling.
This is sampling. This is how you choose the people that are. If you're doing a quantitative study, you should try and avoid purposive sampling or convenience sampling, which is not always possible. You know, like you shouldn't. You know, if you're doing a study on like your example was a good one. If you're doing a study on the impacts of running therapy on patients with mental health, you know, if you say, well, I chose the people who actually enjoy running and told me they enjoy running, you know, like it's important, you know, you know this because we talked about sampling and bias, but you need to explain that here to say, and in a sense, what you're doing in the sixth section is convincing the committee that will evaluate your protocol, yourself and your readers, that your sample is valid. Then we have the sample size, and we talked about sample size calculation.
Actually, this is what I have.
Yes.
So you take all patients.
So in that case, what you're doing is it's not really it's your population. If you have all your patients, then you're not sampling, you're not taking, if you have all your patients, you say, well, this is all the patients I have, so I'm using all the patients available. And then what you will need to do is in your limitation section to explain that it depends what you want to know. If you're doing a study on, you know, outcomes in the patients, in the urology patients in the north, then all your patients is a valid sample. If you're going to choose some patients within this group, not all of them, but some of them, then you need to explain that procedure. The sampling, okay? But if you're using all of them, if you say this is the population I have, then what you will do is in the limitations, you will explain that you are restricted by the patients that you have, and you will describe their characteristics, and you will compare them to, you know, the general population, for example, to try and show and understand how representative or different they are from the you know, all urological patients in Israel, for example. But you're right, there's nothing you can do about it. That is your hospital, that is the patients you have. It may be a problem in you know, it depends what you want to do. Like, for example, if you are working in Ziv, then maybe one of the limitations will be that the outcomes that you will see will not necessarily be generalizable to patients in Tel Aviv or Jerusalem, because, you know, the socioeconomic level is different, the makeup of the population is different. All you need to do, you can't change your patients, but you can explain why you think what are going to be the limitations in using this group in terms of generalizability, etc.
And sample size, maybe.
Yeah, and sample size. If it's, you know, if you only have 30 patients or 40 patients, again, that is what you have. So maybe there are some subsections. You know, if you have a small group, you cannot, if you have 10 patients, you probably cannot divide them into age groups, because you're going to have like 1 or 2 in each group. So this is a limitation. You can only look at it globally, you know, overall. And this is where your objectives need to be realistic with the setup that you have. Make sense? Okay. Then you have to describe the sample size. And we talked a little bit about sample size calculation, explaining, depending on how you're doing it, if you're doing an intervention, looking at how many people you want to recruit. If you're starting with the number of patients, looking at the power that the number you have gives you. And here you can explain, you can justify your objectives and the sub-objectives based on your sample size calculation. So you say, this is a small study, I have 30 or 40 patients, and I can only determine the overall incidence. I'm not able to determine the incidence in particular age groups, for example, because in that way you will preempt, a few months down the line when you write the paper, you don't want the reviewer to say, oh, why didn't you do it by age group? Or you say, I explained that in the limitations, and I explained that in my protocol, and therefore you put it in the paper because you're limited by the sample size. Okay. Everything clear so far? So you see, it's a lot of information, but you can see how if you do this before you start, it makes your life so much easier, and it also prevents mistakes from happening. Then we go into the data itself. Okay? So this is a really important section for the ethics, because the ethics committee needs to make sure that A, you're only collecting data and information that you need for your study, that it is collected and stored in a way that is adequate. Yeah, so you should only collect the data that you need for your study. If you're doing a study on surgical outcomes, you don't need to collect information on sexual orientation. You shouldn't have information that is not relevant to your study, because that is an ethical issue. So you need to explain to the reader and to the VAD what information you collect. You don't need to. What you should do, what is good practice and what is actually necessary generally for the ethics committee, is to attach your data collection tool to your protocol. So if you're doing a questionnaire, you actually say Appendix 1 is the questionnaire. If you're building a data set, you can put the blank, not the actual data, but the fields that you're collecting as an appendix. Here you just give a general description. You say, we will collect information about sociodemographic characteristics, about exposure, age, etc. You kind of give an overall explanation. You don't need to list every single field if you attach your questionnaire or your data collection tool. But you need to, again, it needs to be clear that you're collecting information that is going to be relevant. It's a good time to check whether you're missing any information that you're going to need. So you don't want to, and this happens, like many times you collect the information afterwards and you're like, oh, I should have collected the time, the day of the procedure, for example, and I didn't specify. So think about it, and we'll talk about quality assurance. Someone, before you submit it, you should get a colleague or someone to look at it, to review it, to make sure, because generally having a fresh eye on it is really useful to say, what about this? If you don't collect this, you won't be able to do this, this, and that. So describe that, and then describe how you collect the data, who collects it, where it's stored. And by the way, when we talk about data, it could be like data in a file on a computer. It can also be samples. So if you have biological samples, you need to explain, how they are collected, how they are stored, how they are transported. So, if you have blood samples, you may need to say, they're going to be stored at -20 in, and then explain that the fridge has a temperature control. Sometimes, like for example, with some of the mRNA vaccines, transport is really important, because if you shake the vaccines, that decreases their efficacy. So in the protocol, if you're doing a study on this, you need to explain that they are transported into, like stable environments, etc., etc. If you're using assays, you need to explain what assays you're using, what machines you're using, etc., etc. So be as specific as possible. Who will collect the data? You know, if you're using students to collect the data, you need to say that here, because it has for the ethics committee, it's important to know who accesses the information. Okay. Then data analysis. So now you explain all the different steps. It comes back to what you were saying. You know, the descriptive part and the analytical part. Before the analysis, you will need to explain how you coding and how you are cleaning your data, because when you get a data set, generally it's a mess. You know, like for example, I don't know, you may have a data set that asks about, you know, if you ask students, for example, to record smoking status of the patients, yeah, you will give them sheets and they will fill it for you. And if your sheet is not, if your data collection tool is not automated, maybe sometimes you will have smoking, you will have 0, or you will have, it will say no, or it will say lo בעברית. You'll have like 3, 4, 5 different ways of coding the same information. Unless if you want to do things really well, when you design your tool, you can restrict, if it's a computerized tool, you can restrict the answers you give, and then you give the person who collects the data a code book to say, I want you to, if someone is not smoking, I want you to write a 0 here, not text, not something else, not the number of cigarettes they smoke. This is the so there's something called a code book, which explains in the data collection procedure how each variable is coded. Mm-hmm. Yeah, and the more standardized it is, the better it is, because the less cleaning you have to do. But generally, often it's not perfect because people don't listen to instructions, and then you will have to clean variables. If you might also you might merge variables, for example. You might, and if you're going to do that, you need to explain that. So especially if you don't have enough, for example, if your outcome is, I don't know, heart failure severity, yeah, in the classic New York Heart Association, there are 4 categories, yeah, NY80, 1 to 4. Now, if you don't have enough patients, you may say, I'm going to group into mild and severe. 1 and 2 I put together in mild, 3 and 4 I put together in severe. If you're going to do these things in your analysis, you need to explain this. You need to really go through the details. For the description, you're going to explain how you're going to present your data. I'm going to describe my sample in terms of age distribution, in terms of socioeconomic status, etc., etc. If you have an analytical study, you need to explain what measure of difference you're going to use. Are you going to use risk ratios? Are you going to use odds ratios? Are you going to use risk difference? If you're going to use stratification, if you're going to adjust for confounding, which we talked about, you need to explain how you're going to do this. I'm going to, in order to adjust for confounding by age, I'm going to describe the incidence in each age group, or I'm going to use a regression model. You need to explain that. Generally, the statistician will help you with that section. Okay, but again, think about it as a recipe that if you gave it to someone else, he could do exactly the same analysis and reach exactly the same results. You mention what software you use. If you're doing a quantitative study, you say, I will use Excel to do the tables, and I will use SPSS, or the statistician will use SPSS to do the analysis. Whatever software you use, mention it here. Okay. We'll come into dummy tables later. Dummy tables are a really good tool. dummy tables are basically, at this stage, you're already thinking about your paper, your outcome. And what you do is you build the tables that you want to see. There's no data yet, but you can start seeing. So for example, if you're doing, your prevalence, incidence of incidental head and neck incidental finding, you can have, age group, and then number of patients, and then proportion of patients with an incidental finding. Just an example. Yeah. In your protocol, you actually build that table already, and you put it as an appendix, and you can refer to it in the. You called? Okay.
It's on cold.
All right.
כירורגים אולי רגילים.
אבל תסתכל, אתה כמה שכבות.
So basically, the more you do at this stage, the easier your work will be, because if you already have in your mind how the data and the results will look like, you will collect the data in that way, and you will not steer it too far away and kind of lose the primary objective. Yeah. It doesn't mean that you have to be like completely strict about it. Sometimes things change a little bit, but overall you should think about it at this stage, and the dummy tables should be again another appendix to your protocol, and try and stick to them. You may have to modify them a little bit. It's really helpful to do it at this stage. Then quality assurance. And this is a really important thing. You need to demonstrate to the reviewer that you really you took some steps to ensure that your approach is of high quality. The protocol that you write, get it reviewed by colleagues. Yeah, send it to that's why you have mentors as well. They will do that. They will peer review your protocol, look at it, and find the flaws, what needs to be changed, what needs to be improved. It's really important. You never do research by yourself without checking with anyone, because you get into a certain way of thinking, and then you will overlook certain things. It's really important. Just like you have peer-reviewed papers, you should have the peer-reviewed protocols. It's becoming more and more common to actually publish if it's a complex big study, you can actually publish the protocol as a peer-reviewed publication, which can be very helpful, because then you get independent feedback. Every step you should try and get validated. So how you collect the data, how you analyze the data, get someone to look at that. The other thing that you should get validated, if you can, is your tools. If you have a questionnaire, get someone to look at the questionnaire, not just the protocol, but the actual questionnaire, to because there are so many things that can go wrong. Questions that are leading, questions that are incompatible, wording that is culturally inappropriate, all kinds of things. So there's a process to validate a questionnaire. We haven't actually done this in detail, but it's important. Piloting is also really important. If you have a data collection tool, make sure that it works. Run the questionnaire. If it's a questionnaire, get a few people to actually fill it, and they will tell you, this question really doesn't make sense. I didn't understand that question. This is really, etc., etc. If you're designing a data collection tool, try it on a few patients. Actually try it with a few patients in real life to see whether you're missing information, whether the information that you collect actually fits the variables that you determined. If you're using a laboratory method, try it on 1 or 2 samples to make sure that the assay actually works, that the samples are, we had this issue recently that we wanted to do an assay, and the samples were frozen at -80 for several months, and then we realized that the samples were not viable. We tried 1 or 2, so we had to rethink how. You don't want to do this once you spent all your time and energy into this. You need to do it as early as possible to make sure that the study is actually going to work. Thinking about the bias and the limitations at this stage is really important. First of all, you will need to include it in your paper. You will need to explain in your paper what are the limitations. It could be that the sample that you have is not representative of the entire country, or that you have a small sample size, or that the type of patients that you get referred are more severe or less severe than another place. All these things you need to explain, and you need to explain how it impacts your results and what you have done to try and mitigate it. Okay?
This is in the proposal level?
At the proposal level.
Oh.
Yeah.
You don't necessarily
You-
know.
Well,
What you know.
you know what you know. You don't know everything, but the things that you can anticipate, you mention them, because first of all, it will force you to make as much amendments as possible to mitigate these limitations at the design stage. Especially for bias, it's important because the only way, the only time you can really address bias is when you design your study. Once you've done your data collection and you realize, oh, I only asked the wrong group of people, it's too late. And then if you peer review it, and it will improve the quality of your study. It will force you to think about amending your design to limit. It doesn't mean that you eliminate everything. It just means that it shows that you understand already what you anticipate the problems, and you either correct them in the design, or you understand how it's going to impact on how you interpret your data. And you should try and do this as extensively as possible at that stage. And you can refer to other sections. So for example, if you say, if you identify confounders, you say, I'm doing this study, but I know that my sample is older than the general population. So you can refer to the data analysis to say, we know this, and we will do a regression model adjusting for age in order to adjust for that. So you can cross-refer to each section. You don't need to write the same thing several times. If it's already addressed somewhere else, you just mention it. Okay. Protection of your subjects is important because it's an ethical issue, and it means several things. It means that you need to demonstrate that you're not going to harm people. You're not going to deny them a particular treatment. If it's data that you're not going to, share their data with the world. So thinking about what are the potential risks to patients is important. And it's particularly important if you're dealing with vulnerable population, children, people with with mental health issues, prison populations, whoever it is.
Not prisons. You have what do you call it?
Like in like in turn, like a closed,
like soldiers. What do you call them? Captured.
Yeah. So they are more vulnerable. So you need to weigh the risks and the benefits to the people who are in your group, and you need to make sure that the benefits outweigh the risks. Sometimes the study does not benefit the patients directly. If you're doing a study on incidental findings in 2018, it doesn't benefit these patients who had the scan 3 years ago, but it will improve health, and there's no risks to these people. I mean, these people are already so. But you need to write that. You need to write that down. If you did, for example, a biopsy on healthy patients to look at the difference, this is probably not an acceptable risk for the people on who you're doing a biopsy. So it's important to show that and to say, we're not doing this. We're doing so. You justify your approach from an ethical perspective, and it's both the benefit and the risk can be to the individual, but the data that comes from these people also can represent a risk, and this is the confidentiality. You need to make sure that you demonstrate that you're not collecting unnecessary data, that you are collecting it appropriately, that you're storing it appropriately, that you're sharing it appropriately. This is a problem in this hospital. It's not just in this hospital, but many times I receive emails with, I still deal with the names and things that I really shouldn't see. We had this issue, especially, if there's a study about healthcare workers and there's clinical details, maybe you don't want to tell me that you are diabetic or that, you have a problem X, Y, or Z. It's not really fair. So you really need to think about this, and it needs to be appropriate. Same with the biological specimens, because biological specimens actually belong to the individual. You need to describe how they're being stored, who has access to it, how long you're going to keep the data. If you have sensitive information, mental health can be very sensitive. Maybe the person will get better, and when they're looking for a job in 3 or 4 years' time, they don't necessarily want people to know that they were an interned patient in a psychiatric unit. So maybe that information, once the study is done, needs to be destroyed. You need to think how long you need to keep the data. There's also laws around that. So all these things you need to.
It's all in Iran by now.
It's all in Iran. Yeah, that's true.
Come on.
That's true. That's true. Yeah. So maybe we need to contact the ethics committee in Iran. Informed consent. Showing that you got the information, you got people to participate, in a way that is informed. They're not coerced into it.
Okay.
For retrospective studies on data, it's not necessary. It's not really an issue. You don't need the informed consent of every patient that had a test a long time ago, providing that you're showing that you're using the data in a responsible and confidential manner. With mental health patients, it's a huge challenge.
Kids, you need their consent
And the parents' consent, exactly. So depending on the, but for example, depending on, what kind of mental health diagnosis people have, actually ensuring that people understand what they're getting into can be a challenge, when you're severely depressed, or it can be difficult. And you need to demonstrate that you've done this to the best possible extent. And then, of course, you need to say that you are seeking ethical clearance. If you already have it, then give the approval number. And this is actually part, you generally include this in the ethics committee. Then the other things that you need to talk about is the practical considerations. How many people, who gets involved, the kind of logistics. And this is important because often people don't think about this, and then it gets a problem. We're going to collect, 250 samples, but suddenly you realize, oh, there's nowhere to store them. There's no fridge. There's no, we want to collect 300 questionnaires, but actually, I don't have the time to collect 300 questionnaires. Who's going to help me? And you don't want to find someone at that point. You want to enroll people at the beginning. So describe all of this, how long, a timeline is really helpful. How long each stage takes. It always takes longer than you think. But if you think about this way, because there are resource implications, and some of you will have access to, when there are samples, etc., will have access to a budget, and you need to think, will my budget be sufficient to actually do this study? And you need to convince yourself and others that it's the case, because if you remember in the first lecture, the finer framework, it needs to be realistic. It needs to be affordable and doable in the time frame that you have, and you need to document that. And then finally, the expected benefits. What is going to come out of your study? Are you going to write a paper? How many papers? Are you planning to, is it a report to the management of the hospital? Is it a peer-reviewed publication? Is it a presentation in a conference? What are you planning? And then the outcome. How is the study actually benefiting health? You know, it will. We expect that the result of your study will change the guidelines about who gets what chemotherapy treatment. We expect that it will change the decision-making around what surgical approach to take. We expect it will change referral procedures to ENT. You need to explain that, because again, it's about demonstrating that you are providing added value through research, that it's not research for the sake of research. And then you add the appendices that we talked about, the questionnaire, if you have a questionnaire, other data collection instruments, if you have them, the dummy tables, the consent form, if it's relevant, if you have an information sheet about the study, you include that. And then in the end, you have your references, and that's it. And if you include all of these, you have a very, very comprehensive document. You will avoid, for example, going back and forth with the ethics committee, because you know they won't come back and say, oh, you know, you didn't tell me this, this, and this. It's all in there. And then when you write your paper, you can see that you already have your background, you already have your methods, you already have most of your references. It saves you a lot of time. So it sounds like a long process, and it is. And what I expect is that you write a protocol and that you give it to your mentor, and your mentor says, you need to rewrite it. And trust me, I've done this many times. And by the time you're on version 17 of your protocol, you want to kill everyone around you. But by the end, you will realize that it's a good process. And this may be a little bit over the top, but as a learning process, it will, you know, I learned this 10 years ago, and it completely changed the way I work and I do research. And, you know, and I've seen, even in the last 6 months here, how not doing this and trying to rush things causes issues down the line. The Israeli way. No, but this is not about, you know, this is international, and it's good not to be too Israeli for some things. No, but this, you know, this is it's not about a culture thing. It's really about good standards, good research. And the last thing you want is come to the end of your study, having collected the data, and realize you can't publish, you can't actually do the analysis you want because you forgot something, you didn't, you know, you chose the wrong controls, you didn't collect a variable that you needed to collect. And going through this process step by step will make sure that this doesn't happen, and will ensure that you have high quality study. So I'm going to stop the recording.